Bismillahirrahmanirrahim. First of all, I am thankful to the organizers for inviting me over here. The topic given to me is updates on use of NOCAS in atrial fibrillation. Nothing to disclose. Just a picture of beautiful city of Multan, where I belong. If you are dealing with arrhythmias, this is the most common arrhythmia you encounter in your clinical practice. Just starting from just a regular rhythm on ECG. You can find a fine fibrillatory waves on ECG with rapid ventricular response and with slow ventricular response. So, with this rhythm you have to calculate the chat-wise score. And when it is 2 or more, then this is class 1 indication to start the patient on anticoagulation. So, why it is important? The most common arrhythmias treated in clinical practice, most common arrhythmia for which patients are hospitalized, and 33% of arrhythmia related to hospitalization, and most importantly, 5-fold increased risk of CVA, 2-fold increased risk of all-cause mortality, 2-fold increased risk of cognitive dysfunction, also associated with development of heart failure and also linked to the sudden death. Every age, race, and ethnic group is involved. So, regarding docs, a fixed dose regimen eliminates the need of monitoring the INR, rapid onset and offset, equal or greater efficacy for stroke prevention, low risk for intracranial hemorrhage, and no interaction with dietary factors such as alcohol and vitamin K containing foods, and far fewer drug interactions. Docs are categorized into oral, direct, and factor 10 inhibitors. Rivaroxaban, apixaban, the first two are available over here. Edoxaban and metoxaban, and direct thrombin inhibitors, dabigatran. This is the coagulation cascade and the factor 10A, which is the target for novel anticoagulants. This is just a comparison between docs and warfarin, not going into detail of this pharmacokinetics. Now the major trials on docs versus warfarin for atrial fibrillation, phase 3 trials, rely on dabigatran, rocket-AFib on rivaroxaban, Astol on apixaban, and GALC AF on edoxaban. So, stroke or systemic embolization, you see far less in docs group, and then major bleeding, far less in docs group compared to AFib in phase 3 trials. So, the bottom line, stroke and systemic embolic events are significantly reduced in AFib patient receiving docs compared with warfarin. Docs have a favorable safety profile compared with warfarin, in particular with respect to intracranial hemorrhage. Then now comes to the indication for docs for dabigatran. The FDA approved indications: stroke prevention in non-valvular atrial fibrillation, treatment of DVT and pulmonary embolism, prevention of DVT and pulmonary embolism. Almost same with the rivaroxaban, apixaban, and then edoxaban, and metoxaban relatively new. So, when you're prescribing docs, you have to, in patient with renal dysfunction, you have to go with the creatinine clearance. If it is less than 15, you can only use apixaban with some cautions, and then moderate, then you can avoid dabigatran. Rest you can use with caution, and it's normal, then you can use any of the docs available. For hepatic dysfunction, you have to do child bug scoring. For child bug A, you can use any of the docs. In B, with caution, and with C, nothing. In case of extreme of body weight, with normal body weight from 60 to 120, you can use anyone. In case weight less than 60, you can use apixaban and edoxaban with caution, and with 120 kg and above, you can use apixaban and rivaroxaban with caution. Algorithm is available if you have to switch between anticoagulants, and which is very easy. And then far fewer drug interaction with docs as compared to warfarin. Now, this is a recent review, a meta-analysis in BMC last month, and they found 62 randomized controlled trials on docs. So, multiple studies are available and much data is available for docs. This is a recent review in Curious Journal in the use of novel anticoagulants in patients with atrial fibrillation and moderate to severe mitral stenosis. But this is a negative in a way that systemic review presents evidence against the use of NOCAS for patients with moderate to severe MS and support the current treatment guidelines in which the contraindication is dogs for non-valvular, for valvular heart, valvular fibrillation. So, for atrial fibrillation and PCI, we have few trials available. Pioneer AFib trial, in which dual therapy with rivaroxaban dosed at non-standardized AFib dosing, 15 milligram with clopidogrel, compared with triple therapy with rivaroxaban 2.5 milligram twice daily plus TAPT, and with VKA, with similar decrease in thromboembolic events and lesser bleeding complications. Then the redual PCI, this trial done on dabigatran with almost same results, similar reduction in thromboembolic events and lesser bleeding complications. Then Augustus trial on PCI in atrial fibrillation patients done on apixaban in combination with P2 millimeters with aspirin, without aspirin, resulting in less bleeding and fever hospitalization without significantly affecting the number of ischemic events than regimen that includes VKA, aspirin, or both. Now, atrial fibrillation in artificial heart valves. Valvular AFib referred to the presence of mechanical prosthetic heart valves or moderate to severe mitral stenosis condition that substantially increase thromboembolic risk and serve as a principal exclusion criteria for the major dogs phase 3 AFib trials. This is realigned trial done on dabigatran in patients with mechanical heart valves, and the study was terminated early as patients with mechanical prosthetic heart valves experienced excess thromboembolic and bleeding events with dabigatran. Now comes to bioprosthetic valves. Overall, the use of dogs in patients with AFib with bioprosthetic valves or other valve repairs still constitutes a gray area in clinical practice because of limited investigation and consensus. So in this, there is no clear-cut guidelines, and you can use as per your own clinical scenario. Now, the reversal agents are also available with dabigatran, idoxaban is available, and additional alpha for factor 10A inhibitors. And if it is not available, then you can use prothrombin complex concentrate. So, just a simple scenarios in which you can use dogs or not, and the simple answers as well. Thank you.